This presentation, it discusses the durability of mitral valve repair for mitral regurgitation due to degenerative disease of the mitral valve. Fibroelastic deficiency, myxomatous degeneration, and dystrophic calcification of the mitral annulus are the three pathologic entities grouped under the term degenerative diseases of the mitral valve. Fibroelastic deficiency is a term introduced by Professor Alain Carpentier to describe mitral valves with normal size, thin leaflets, and with attenuated chorda tendina, and the regurgitation is usually due to ruptured chorda tendina. Myxomatous degeneration is a common cause of degenerative disease of the mitral valve, and its pathologic spectrum is quite broad, and it ranges from minimal change localized to a small area, usually the prolapsing segment, to very advanced degeneration with thickened and voluminous leaflets, massive annulus dilatation, and displacement of the posterior annulus with atrialization of the posterior leaflet and calcification of the annulus, chorda tendina, and even papillary muscles. This echocardiogram shows a young patient with advanced myxomatous change of the mitral valve. Finally, dystrophic calcification of the mitral annulus is the third entity that is grouped under degenerative disease of the mitral valve. It can occur in isolation or in combination with fibroelastic deficiency or myxomatous degeneration of the mitral valve. We will review all publications that have provided data on the durability of the mitral valve at 15 years and beyond. The first paper is one of my own, and I'd like to describe in some detail. It was published in Circulation in 2013. We reviewed 140 patients operate on from 1985 through 2004. 7 patients had a second repair during this time interval, and they were re-entered as new patients for analysis. The median age was 60 years, and most patients were men. 10% of the patients had history of infective endocarditis or even active endocarditis in a small proportion. Approximately 1/2 of the patients had minimal or no symptoms, and 21% had atrial fibrillation at the time of operation. %60 of our patients had normal left ventricular function, and the remaining had some degree of impairment. 14% had coronary heart disease, and only 3.7% had moderate or severe tricuspid regurgitation. Less than 1% had no leaflet prolapse, and the remaining had posterior leaflet prolapse, isolated anterior, or bileaflet prolapse. We also recorded the degree of myxomatous change on the leaflets. We classify as none or mild when the leaflet had minimal changes or only in the prolapsing segment. Moderate when the leaflets are opaque but still pliable, and severe when the leaflets are very thickened, at least with 3 mm by echo, and somewhat fibrotic. This slide shows the operative data. Early on in our experience, we did not use annuloplasty ring in patients with the small leaflets because we were concerned about stenosis. And indeed, 9.2% of our patients had no annuloplasty ring or band. The remaining patients had Carpentier ring, Durand ring, but most of them had Cosgrove band. Prolapse of leaflets were corrected mostly by creation neocord of Gore-Tex. 2.4% had resection of the calcium bar and reconstruction of the mitral annulus, as we have described in the past, in patients with dystrophic calcification of the mitral valve. This slide lists the other procedures performed in addition to the mitral valve repair, and also the cardiopulmonary bypass and the aortic clamping time. Patients were followed prospectively, initially with annual echocardiogram, and then as they became more stable after the 4th or 5th year, echocardiography was done every 2 or 3 years. The median follow-up was 10.4 years. The follow-up was complete in 98%, and echocardiographic follow-up complete in 95%. There were 4 early deaths and 179 late. Out of 179, 81 were cardiac or valve related. The cardiac and valve related were sudden death, congestive heart failure, stroke, myocardial infarction, anticoagulation related bleeding, and other causes. This slide shows the estimate survival up to 20 years. And this slide shows the survival of the patients according to the New York functional class. The black line shows the patient with minimal symptoms, and the red line patients with more advanced functional class. These patients with more advanced functional class were on average 5 years older than the first ones. Thus, they're not comparable. However, if we match them for age and gender, the results are the following. Patients with low functional class, New York class 1 and 2, had the same survival as the population in general of Ontario. The patients with more advanced functional class did not live as long as the population in general, indicating that mitral valve repair did not restore lifespan to normal. The independent predictors of valve-related death were age by 5 years increments, functional class by level, and preoperative infective endocarditis. Cardiac-related mortality, the independent predictors were age, functional class, and left ventricular ejection fraction per level. "38 patients require reoperation of mitral valve during the follow-up. 24 for recurrent severe MR, 5 for mitral stenosis due to penus, all of them on Durand rings, 5 for hemolytic anemia, and 4 for endocarditis. We are able to re-repair only 8 cases, usually patients in whom the operation was done in the first 5 years, and 30 patients require mitral valve replacement. This slide shows the freedom from reoperation at 15 and 20 years. Was 95% at 15 years and 20%, 94% at 20 years. The image on the right side shows the competing risk for reoperation of mitral valve is highest on the first 40 years and then plateaus to a very low probability. The independent predictors of reoperation in mitral valve by multivariable analysis were isolated anterior leaflet prolapse, myxomas degeneration per level. In other words, more advanced the degeneration, more likely for the repair to fail. Duran ring annuloplasty, largely because of the 5 cases that developed mitral stenosis, and duration of cardiopulmonary bypass. I believe that duration cardiopulmonary bypass is a marker for something else that we did not record in our databases. Echocardiography during the follow-up showed that 98 patients developed recurrent MR, more than mild, 37 severe, and 61 moderate or either mild to moderate. This slide shows the estimated freedom from recurrent mitral regurgitation greater than mild at 15 and 20 years. The independent predictors of recurrent mitral regurgitation greater than mild by multivariable analysis identified age by increments of 5 years, mitral end reconstruction, isolated anterior leaflet prolapse, the degree of myxomas degeneration, repair without a ring, and also duration of cardiopulmonary bypass for the reasons that we speculated before. In summary, during a mean follow-up of 10 years, they extended up to 26. 51.3% of the patients were alive and free from reoperation in mitral valve. 23.7% died of non-cardiac deaths. 19.1% are cardiac or valve-related deaths, and only 5.9% require reoperation on the mitral valve. The next paper we'd like to review is by Alfieri's group from Milan. In this article by Gibonis and co-authors, they describe the very long durability of edge-to-edge repair for isolated anterior mitral leaflet prolapse. They had only 139 patients, relatively young, with a mean age of 54, and just over half were men. Most patients, at least 2/3 of them, were asymptomatic or minimal symptoms. Only 30% had class 3. 20% had atrial fibrillation, and the mean ejection fraction was 56%. They reported a freedom from reoperation of 89% at 17 years. And if you add recurrent, severe, and moderate mitral regurgitation to the reoperation, 17 years later, 80% are free from both, which are quite spectacular results, considering that this is only anterior leaflet prolapse. The next paper that reports long-term results of mitral valve repair is by Professor Carpentier group, and published the supplemental circulation in 2001, a long time ago. They had 162 French patients with a mean age of 56, and the patients were operated from 1970 to 1984, again, long time ago. Very few were class 1 and 39% class 2. Most patients were quite symptomatic. 45% had atrial fibrillation, again indicating that this patient had more advanced disease. The pathology according to Carpentier functional class was type 1 in 6% and the type 2 or leaflet prolapse on 94%. Posterior leaflet prolapse was the most common one, followed by bileaflet and then anterior leaflet. This graphic shows the freedom from reoperation on patients who had mitral valve prolapse. The best outcomes were obtained in patient posterior mitral valve leaflet. The anterior and bileaflet prolapse, the freedom from reoperation dropped to 80% at 15 and 20 years. Overall, they had excellent outcomes with a freedom from reoperation 94% at 10 years and 92% at 20 years. Finally, the last paper I'd like to present to you that has data on durability beyond the 15 years is from Mayo Clinic, and again very old, published some 14 years ago. In this paper from Mayo Clinic, the patients were operated on from 1980 to 1995. 917 patients, and they include those in whom the valve could not be repaired and was replaced. They are much older than in the previous series, and like in our practice, about half and half as far as symptoms concerned. Half the patients had mild symptoms or no symptoms, and the other half quite advanced. 42% had atrial fibrillation. Repair was accomplished in 74% of the patients. Higher if the pathology was posterior leaflet than in anterior leaflet. This graphic shows the probability of reoperation, and the dotted lines are the repair. We encircle the outcome at 15 years. The reoperation at 15 years in the entire cohort was 16%. However, if you take a look at the next slide, they indicated that in patients who had no residual mitral regurgitation in the operate room, the probability of failure was lower than in those who are left with some residual regurgitation. In addition, they also examined the type of prolapse. Patients with posterior leaflet prolapse did by far better than patients with anterior leaflet prolapse. And they separated the experience on the 80s from the 90s, because in the 90s they introduced Gore-Tex to repair anterior leaflet, and the results are much better. Mitral valve repair is the ideal procedure to treat mitral regurgitation for degenerative disease of the mitral valve, particularly in asymptomatic or minimum symptomatic patients, because it restores lifespan to normal. Mitral valve repair is feasible in more than 90% of the patients in units with experience in this procedure. Repair of posterior leaflet is more durable than repair of the anterior leaflet prolapse or bileaflet prolapse. Mitral valve repair does not arrest the degenerative process, and some patients will develop valve dysfunction in their lifetime. Actually, we have found that patients with more advanced degenerative process are more likely to develop valve dysfunction during delayed follow-up. Thank you.